So if you ever have any contact with Oticon, you'll know Tammy because she is the star of Oticon. She has been instrumental in developing and executing a comprehensive sales strategy to drive new business and acquisitions to foster exciting or existing client relations within the Puget Sound area. Prior to her serving the account executives, she devised innovative strategies to drive new business and foster existing relations in both private and government services in both Washington and Alaska. She has a doctorate degree in ideology and from Solace University in Philadelphia, PA. So she's been around. A master's of arts and ideology in Northwestern University. She's pretty committed to this industry, going through all of this. And a bachelor in science of communication sciences and disorders in St. Louis, St. Louis University in St. Louis. Also, today she's going to be talking about infection control. So over here to my left, I have a big bottle of hand sanitizer because she's just going to give me the chills. So I'll turn it over to you.
Thanks, Gary. Appreciate that. That was very nice. So I'll give you guys just a quick background on this. I've actually been, teaching this class for probably, I think, 18 years now. Oh gosh, I think we're going all the way back to the Oregon Hearing Society meeting a long, long time ago. Ron Shire had asked, when I was over at Unitron, Ron had asked if I would be willing to give a talk. And I was like, what do you want me to talk about? And I said, I can talk about product, but we weren't in the process of launching anything at the time. And I was like, something else you want me to go over? And he's like, actually, we need to have our infection control class. We need to meet our requirements. So I agreed to do that. I was like, I'll give you a research. I was like, I'll do research and I'll figure it out. I was like, I'm not going to be an expert by any stretch, but I'll do a research presentation. And that's kind of been the basis of the ones that I've done here since, really kind of kept the same structure. For anyone who's taken the class before, I've been required to. I just like to tell you guys that my end goal of this class is that you're going to want to bathe in hand sanitizer by the time you're done with this course, for sure. And really, as I've mentioned in previous classes, if you've been at it, I really do hope, like, kind of the end goal of this too is for us to kind of take this approach from infection control. It's not to come off as self-righteous or kind of like talking down on people about it, but it's really just to kind of think about this mindset that, every patient that we encounter in our clinic can be both simultaneously, highly infectious and not be aware of it, but also be immunocompromised and we may not be aware of it. So we have to really treat each individual patient as they come through almost with as fresh of a start as we possibly can, right? And offer that for them. And there's legal consequences to this. So we'll talk about that too as kind of part of our coverage on what we can do. What this class is not a referendum on masks. So I always like to put that out there. It was, I think, far more of a big thing back a couple of years ago when I did the talk at Tri-State. It's just not an argument that I want to engage with, right? It's part of PPE. It was part of PPE when I started teaching this class 18 years ago. That has not changed. So so you should not get into debates with people about that. Like, this is just part of our overall protective equipment that we have, and it is there for better or worse, right? If you guys have questions, I don't know when I'm on the Zoom. It's been a while since I've done a presentation on Zoom. I'm not sure if I will even have access to questions. So Kaylin, if you see somebody post a question, maybe you could just pop in and like, jump in with the thing. And let me know if there's a question about it, and we'll do what we can to answer. Oftentimes, a lot of what questions that get asked will be stuff that will be covered anyways at some
Yeah.
point. I'll
Do
be happy.
you want to just wait till the end? Because that's kind of, we really haven't had a lot of questions, and
Yep.
even at the end too. So
Fair enough.
okay. All right.
That being said, I also know that I am the last thing that is keeping you guys from a happy hour drink. So I want to be plenty respectful of that for all of you. So you get the chance to kind of obviously learn something, hit your requirement that you need to for infection control for our state requirements, and hopefully learn something, or at least have stuff reviewed for you, and then be able to enjoy your weekend or enjoy your night before we have classes tomorrow.
All right.
So I am going to let me make sure that my stuff here is set up properly so we can start in the right way. Okay, now we're going to see how this works. We're going to try it. Okay. Don't think I need to share sound, but I will do it just in case. And come on, there we go. All right, can we all see the screen there? We're good? Okay. All right, I'm going to turn off my video just so that we can hopefully keep the bandwidth okay. And we will walk through this. So, and everybody, this is our infection control class. So, as we go through what we have here, let's see if I can get this set up. There we go. So, contents. So, do an introduction, walkthrough, do a quick walkthrough in the immune system because I know that we have just a little bit less than an hour. Talk about infectious diseases, current infection control practices, cover OSHA requirements and universal precautions. We'll discuss practical applications and an infection control plan. I do not have case studies because that was part of our COVID. That was actually part of Gus's COVID request when we had AAA, or when we had Tri-State at the last meeting. So I forgot to take that off of the class. So I always like to start off these lectures with my why. And so there's our family. We are massive Kraken fans. We got to go to the very first home opener. We are season ticket holders. We're part of a group, so we get to go to anywhere from about 8 to 10 games a year, which is the perfect amount to have to drive into Seattle for from where we live. We managed to get tickets to the Winter Classic game, which is the game that is held every year on New Year's Day at an outdoor stadium. So Seattle got to host it this year. We had the very first shutout of a team because this is kind of a nationally televised game. We had the very first shutout, which was awesome and amazing. And my child was choosing to not participate in this particular picture, but that's a better picture of him from a couple years ago. So we had torn down our house and rebuilt it, and he got to ride in the digger thing, whatever that equipment is. That I don't know what it is, but close enough. So there was some conversation about our dog, and that is our dog. His name is Tucker. We think he's a rescue dog. He was actually abandoned in a park. He's our resident chaos agent. So while we don't approve of that behavior, sometimes we understand it because he has a lot of energy and he's just a crazy dog. That is him right before Christmas time with his emotional support yam that he took off the counter. My husband's making sweet potatoes one night. So, but that's Tucker. We love him. He's very sweet. But those are my whys. So let's dig into the basics. So we talk about modern infection control. Of course, one of the favorite stories I always like to talk about is Ignaz Semmelweis. So he was a Hungarian obstetrician in Austria who discovered that death rates were dropping from about 18% to 1% when decontamination of the hands were done, just beyond simple washing. And basically, we were seeing death due to infection had dropped off quite a bit. He discovered there were problems from physicians that were working with patients directly after conducting postmortems. So they were carrying kind of a disagreeable odor with them that wasn't removed from hand washing. So from your basic hand washing. He also identified cross-contamination between patients. So he recognized that disease, remember just before the discovery of bacteria, could be spread by linen and air. For these incredibly groundbreaking discoveries that he made, he was censured by his hospital and sent to an insane asylum in his native Budapest, where he, ironically enough, died of an infection post-operation. Louis Pasteur was a French scientist, the father of microbiology. He developed the idea that microorganisms were infecting animals and humans and could cause disease. He proposed preventing the entry of microorganisms into the human body, which inspired Joseph Lister's work. He was the creator of vaccines that were created using artificially generated, weakened versions of disease. And then Joseph Lister was a Scottish surgeon who used carbolic acid on gauze to dress surgical wounds and basically created the modern day antiseptic. With his work, we saw post-surgery mortality drop from 50% to 15%. So for current infection control in the modern day, so HIV and AIDS really came into focus in the early 1980s. Hepatitis B emerged as a health risk in the 80s and the early 90s. In 1991, based on these issues that we were seeing with both AIDS and hepatitis B, OSHA sets the rule for bloodborne pathogens. Many states, including Washington and Oregon, have adopted rules for themselves. And we'll talk about why bloodborne pathogens is applicable to our actual profession. So our immune system and how it works. So when we talk about immunity, we actually talk about two different types of immunity. We talk about non-specific immunity and specific immunity. So these are basically kind of layered defenses of increasing specificity. They go from basically non-specific to specific, which I know sounds kind of obvious. We talk about non-specific immunity. Basically, we're talking about kind of generalized immunity here. So when we talk about your integumentary system, this basically your skin. It's the tough outer layer of the skin, which is generally dry, and resident bacterial population and natural secretion of sweat creates a high concentration of salt. And this basically makes your skin an inhospitable environment for many microorganisms. The surface of the human body contains 10 times more microorganisms on the skin than it does cells. It is estimated that resident or normal body flora consists of over 1,000 different species of microorganisms. These colonies of microorganisms also help to prevent opportunistic or transient microorganisms from taking hold. Your lymphatic system is part of the larger circulatory system, only circulating lymph fluid instead of blood. It also carries lymphocytes and white blood cells. Your respiratory system, the lungs, contains ciliated epithelium and mucociliary blankets that line the respiratory tract of your throat and your lungs, and they trap invading microorganisms and they kind of waft the bacteria out. The cough reflex helps to expel them, and 90% of inhaled material is cleared from the respiratory tract within an hour. And then we also have our lovely GI system, the gastrointestinal system, right? So gastric acid and peptide enzymes in the stomach create a naturally acidic and inhospitable environment in the large bowel, and resident bowel flora inhibit growth of potentially pathogenic bacteria. And then, of course, we talk about mechanical methods, which talks about all those different fun ways in which we expel bacteria that comes in that's not supposed to be there. I don't know that I need to go into too much more detail about that because I think that's all fairly obvious for everybody, right? I'm sure somebody will have a question in the chat. So specific immunity. So specific immunity refers to that which is acquired through natural or artificial means. Natural immunity is acquired by everyday encounters and exposures to disease-causing agents and pathogens, naturally or unintentionally. Artificial immunity is artificially derived by vaccination, where the disease-causing agent or pathogen is deliberately exposed to the body, however, in a harmless or attenuated form. Right.
Tammy, real quick, I hate to interrupt you. Your talk has a lot of flow to it, and your voice is fluctuating awkwardly.
Oh, okay.
So I don't know if I tried to message you to not interrupt you. It's
sorry.
Yeah, I wasn't sure if there was a setting or something you could adjust.
That's a good question. I don't actually know because I'm using my computer microphone.
Okay, so if you go down to where the icon is to mute and the little arrow to get to your audio settings,
okay.
wonder if we can
Select a microphone, same as
some
the
sort of
microphone.
adjustments. I don't know what it is to adjust though. I mean, we could try to keep going. Where it says audio profile and background noise suppression, maybe just change whatever your setting is set at and we can try it.
Let me see. Mic. Automatic. I can change it from automatically adjust microphone volume. Should we do that?
Yeah, let's try that.
Okay.
I like the sound of it.
Okay, so let's see.
Let's
I don't
see
know
if
if this is
the
going to
sound
sound
changes.
good.
Carry on. I'll let you know if it didn't change.
Okay, sounds good. We will see if this works. And I will try to stay as close to the front here as I possibly can to figure out where in the world the microphone is on this thing too. I think I see it, but I just want to make absolutely sure. Okay, so as we talk about specific immunity, yep. So basically talk about passive immunity. Passive immunity is passed from one body to another and no memory is formed. So for example, immunity that is passed from the mother to the child via the placenta. So that is stuff that's not actively acquired and basically allows us to move forward. Okay, I'm going to get this back in my little system here. There we go. Okay, so when we talk about infectious diseases. Get myself a little bit less here. Okay. So viruses are the smallest known infective agents, approximately 100 to 1,000 times smaller than the cells that they infect. A virus needs to access a host cell so that it can substitute its own nucleic acid for the cell's DNA. Once a host cell has been infected by a virus, it bursts and releases as many as 10,000 new virus particles, which go on to infect other host cells. Does this seem to be working better, maybe? Oh, we drop one?
Yes.
Okay, there we go. Bacteria. It is estimated there are between 500 and 1,000 different species of bacteria that inhabit the body. There are 50 species of bacteria that are known to cause infection in the human body. Others are opportunistic, causing infection when defenses are breached. One of the key weapons that bacteria possess is their ability to produce and release toxins, which force an immune response. So examples of this include staphylococcus, tuberculosis, and otitis media, or the disease for our middle ear. We talk about fungi. It's a plant-like cell that can reproduce as a single organism, like yeast, or as a multicellular colony, like mold. So Candida, otitis externa, those are options, examples of things that directly affect what we do within our clinic. Opportunistic infection. So this is where commonplace microorganisms that do not produce infection in individuals with intact immune systems, but can take the opportunity to infect a body with a disabled immune system. So this can actually be something even along the lines of your resident body flora can also be considered opportunistic if it's placed elsewhere on the body. So if there's, our flora, our body flora that we have is specific to certain areas, but that may not mean, even if it's of our own body, that if it ends up somewhere else, if things are not properly cleaned, and we end up with some flora from one particular body part onto another part, or enters into another thing, that we're able to properly fight it. So infectious disease results from invasion of a host by disease-producing organisms. So examples of non-communicable infectious diseases include anthrax or Lyme disease. And communicable diseases are infectious diseases that may be transmitted from one person to another, for example, like influenza or measles. So I'm going to talk about the process of infection, how these can happen, right? Because we've gone through all these different bugs and all these different options and all the different ways you can possibly get sick. So let's talk about how it happens. So we talk about process of infection. There's contact transmission. And so that's spreading disease through microbial exposure by touching or coming into contact with potentially infectious objects. Okay. So when we talk about that, there's a couple of different means of this. So direct contact. So exposure occurs by coming into direct contact with potentially infectious microbes without intervening persons, barriers, or conditions. Indirect contact. Exposure occurs by coming into secondary contact with contaminated objects. Somebody touches something and they contaminate an object, and then you touch that to follow up, right? And that can happen. Droplet transmission is exposure to microbial droplets expelled in the air that come into contact with mucous membranes lining the eyelids, nose, and mouth. So examples of this, of droplet transmission, include if a patient sneezes, patient 1, patient 0 sneezes or coughs and sends stuff out into the air, and then it comes into contact by either somebody breathing in those particles or the particles coming in through your eyelids or through your eyes, or your nose or your mouth. And then there's vehicle transmission. So this is a manner of potentially spreading disease through ingestion of or exposure to contaminated substances, including food, water, blood, or bloody substances. So this is oftentimes where we see like hepatitis can get spread very easily through vehicle transmission. I know going way back, Typhoon Mary was always causing problems, right? Because she was cooking and she was spreading typhoid to other people because she herself was infected and continued to cook and then spread disease to other people. Airborne transmission. So it's a manner of spreading diseases through microbial exposure that's suspended in the air as either droplet residue or dust particles, right? So droplets can be airborne, as we're aware of that. Droplets also can be transmitted through kind of that secondary transmission. Somebody sneezes on a table and it's not clean, and somebody puts a hand on it, right? Or somebody coughs and they cough all over something, and then you're touching things without having cleaned off the thing itself. Another method of this, when we're talking about dust particles, is something like the hantavirus, right? So that can be caused from people that are cleaning their garages out, and there's mice poop that contains the hantavirus, and it has been basically kind of brought down to dust. As you're swooping things up, people can kick up dust and they can inhale the hantavirus in that manner. So we talk about vector-borne transmission. So this is a manner of spreading disease whereby insects or animals carrying a pathogenic agent transfer disease by interacting with a susceptible host. So, for example, mosquito-borne transmissions, right, can send stuff for malaria, West Nile, Zika, example. Animals that have rabies can do this. It's by vector, right? So you're not going to catch rabies unless you get bit by somebody, by an animal who's infected, or I guess a person, right? We're just going to keep it, equal to all animals at this point. Immunosenescence. So this is basically a weakened immune system. And this is really, we see this a lot more with the elderly. Basically, it's that decreased efficiency of innate and acquired responses, a decrease in terms of antibody and lymphocyte responses, lowered response to vaccination. There's a reduced cough reflex. So if they're inhaling things through droplet transmission or through dust transmission or airborne transmission, they're going to have a much more difficult time expelling that from their system, and it'll have a much easier way of taking root in their lungs and in their pulmonary system. Skin, as we know, is much more easily damaged and prone to tears, right? So that also kind of affects that first step of that integumentary system that's there as that protective measure. That also potentially allows for cross-contamination of even just your natural flora and your natural bacteria. This can also be caused by nutritional status. So if you're dealing with patients that are having some concerns with regards to some potential dementia issues where they're just not remembering to eat and their nutrition is down, or they're not eating as much just in general, and so they're not able to keep up with their immune system. Loss of mobility, a coexisting illness or disease, an underlying illness or treatment, and also medication, of course, can cause for a weakened immune system, depending upon what they're taking. So when we talk about different types of diseases in here, so CMV is a herpes type virus. and it's the leading known cause of auditory defects in children. Overall, it does not affect healthy individuals, but this is where that immunosenescence can kick in, right? Half of all persons under the age of 30 have been infected. So for immunocompromised persons, this is one of those opportunistic diseases, right? It can sit dormant. You end up with an infection, or you end up with a depressed immune system for various reasons. This can result in blindness, gastrointestinal CMV, and encephalitis. This can also cause severe liver and spleen damage to infants infected in utero. So this is one of these diseases that it's a huge deal if patients are not, if somebody who is pregnant and has not had CMV ends up getting CMV while they're pregnant, because it doesn't get they don't have any immunity to it, and it can affect and infect infants that are infected in utero. Are we still good, Kaylin? You send me a thumbs up. Things sound good for the microphone.
Yes, it's perfect. That's what needed changed.
Audio adjusting was the problem.
Yeah, no worries. You're good.
Okay, awesome, good. Glad to hear.
Keep going.
So, perfect. Hepatitis itself refers to inflammation of the liver. So liver function is compromised. There's 6 distinct types of hepatitis, and a person may have multiple ones at the same time. The incubation periods may vary, and different viruses can cause different types of hepatitis. So we're going to go over just a couple of the most important ones. Hep B is the most prevalent form. 1 in 20 persons in the US have been exposed. Infected individuals may not realize they've been infected, and this can be transmitted through saliva. The great part about this disease is it can survive for up to a week at room temperature outside the body. So somebody's talking to you and they spit while they're talking and it lands on the table. And when was the last time you wiped off your splash surfaces or your countertops or your tables or your end tables in your front room, right? Just throwing that out there. Again, my goal is for you guys to want to take a bath and hand sanitizer after this. There is a vaccine that's available. If they do end up with if a patient does end up with Hep B, it can cause scarring of the liver, liver failure, liver cancer. This does affect infants and children and immunocompromised patients the most. I think I actually took off the Hep C stuff. I did, because I jumped right into diabetes. So diabetes, again, another immune disorder here. It's a metabolic disorder in which the body does not properly produce or utilize insulin. So there's 3 main types. And actually, I think there's been a 4th one that we can kind of get into a little bit here. Type 1 is diabetes mellitus. Type 2 is more of an adult onset. And then type 3 is really, the 3rd type is gestational diabetes. Type 1 accounts for 5 to 10% of all diabetes cases. No insulin is produced. And so we need to have artificial insulin produced for them. Type 2 accounts for 90 to 95% of all diabetes cases, and not enough insulin is produced. With gestational diabetes, that is usually caused as an onset of a woman being pregnant and developing diabetes. There's tests for that, just because of the additional strain on her system. It's actually a very high likelihood if a woman's had gestational diabetes that she will end up as a type 2 diabetic later on in life at some point. Diabetic patients may have depressed immune systems, especially if you're type 1, but type 2, they have seen a significant number of type 2 diabetics that have depressed immune systems. There's a lot of checkpoints along that case if you are diabetic of things to continually keep checking on. Interestingly enough, there's a study from the Annals of Internal Medicine that came out about 12 years ago, I believe, that shows that patients who are diabetic are 2 to 3 times more likely to have hearing loss, right? Because they're dealing with issues with a blood flow issue, with their endocrine disorders. As of 2011, according to CDC, 64% of those diagnosed as diabetics are aged 50 and up. So patients may not think to have this conversation with you about them being a diabetic, right? They may not put 2 and 2 together or understand if there's even a link. So if you don't have it in your case history, I would make a point of making sure to actually ask this of patients, because this also affects for diabetics if you are doing any kind of wax removal, or if you're doing ear wall depressions. Patients who are diabetic tend to have a slower immune response to healing for wounds as well, especially if their diabetes has been largely unchecked or untreated. Patients who are undergoing chemotherapy have an increased possibility of hearing loss, especially if they use cisplatin, and can have suppressed immune systems. I can tell you from experience with friends who ended up with, who were actually relatively young, who ended up with different treatments and chemotherapies for cancers. I mean, while they were in their like early 30s to mid to late 30s kind of thing. So very, very young. The conversation about hearing issues and ototoxicity with chemotherapy was never discussed with them. Even with patients who had things that we know very clearly, like cisplatin, that was never a conversation. So again, this is a conversation to have with patients. If you know somebody who's going through cancer, or if it comes up, it's worth having that question with them too, and also understand if they do have an immune, if they do have a suppressed immune system. Yeah, tuberculosis. So it's a bacterial infection that mostly affects the lungs, but can affect any part of the body. It's transmitted through the air. Healthy persons can breathe in TB particles and not develop an infection. And this is what's known as latent tuberculosis. Immunocompromised patients, you know, like your cancer patients or your diabetics, are more susceptible. Symptoms include cough, weakness, loss of appetite, fever, chills, night sweats. And to add to the fun, multi-drug resistant strains of tuberculosis have developed. Latent TB cannot infect others, and tuberculosis can develop under the right conditions. So HIV and AIDS. HIV is the disease that causes AIDS. It is transmitted through direct person-to-person contact through bodily fluids. Incubation period can last up to 10 years, and it can cause hearing loss, lungs for cardiac and blood flow issues. And a recent study by the CDC has found that up to 26% of those infected with HIV were not aware and had no idea. This is going back a little bit, and I think the numbers are actually probably higher at this point, that people who are aged 50 and older account for 24% of the estimated 1.2 million people living with HIV in the US. Approximately 5% of new HIV diagnoses were in patients aged 50 or older. People aged 50 or older accounted for 27% of AIDS diagnoses in the US, and they also accounted for 37% of AIDS deaths in 2013. Older Americans are more likely to have a late HIV diagnosis and thus a shorter HIV to AIDS interval. There's a lot of treatments that are out there now that have actually helped people not only survive with HIV, but thrive with it. It doesn't mean that they're not immunocompromised though. And, you know, especially with kind of older generations, there's still that stigma of HIV and AIDS. And so patients may be more reticent to be willing to share that information that they may have HIV or may have AIDS. But that, again, this is part of that. We need to treat every patient as if they're potentially infectious, they have a cold, and also potentially immunocompromised, whether they know it or not. Candida, it's a fungus. It's part of the natural flora of the intestinal tract. When it is where it is not supposed to be, developments can range from skin rashes to mucosal infections to even things as serious as meningitis, endocarditis, and pulmonary infection.
Tammy, you're fluctuating just a little bit again. I'm not
Sorry,
sure what
my voice is also fluctuating a little bit too.
Oh,
So.
okay. Well, I can relate. I understand that. No worries.
Yeah,
you know,
my apologies. Yes. Speaking
No,
of immunocompromised, I've been fighting a cold for the last few weeks. I think I'm long past the infectious part. It's just haven't quite kicked out the
going around. I think all of us can relate. So
yes. So
right.
timely discussion. So we talk about Pseudomonas aeruginosa. It's an opportunistic bacteria transmitted through direct contact, indirect contact, and vehicle transmission. It resides in moist areas and in organic vegetation. can also cause endocarditis, pulmonary infection, chronic otitis externa, and malignant otitis externa. And they talk about staph infections. So two categories, the coagulase positive and coagulase negative. Staph aureus is only the one that's considered coagulase positive. It can create boils, carbuncles, endocarditis, pneumonia, osteomyelitis. It's commonly associated with a high percentage of the acquired infections in hospital settings. And it is, of course, found on the skin and in the noses of healthy people that are able to easily fight it off. So we're going to jump into MRSA here. So it is spread through direct contact and is resistant to most of the psyllin antibiotics. So penicillin, those kind of ones. It can be treated with vancomycin, which we know that vancomycin has up to a 12% ototoxicity rate. So again, we can treat it, but it means that patients are oftentimes going to be dealing with potential hearing loss as well. And then diving into COVID-19. So transmitted through direct contact, as well as airborne and droplet transmission. Infected particles are inhaled into the respiratory tract and may spread from there. We can also be transmitted through infected particles that are reaching the eyes, nose, and mouth, and eyes are either from a sneeze or cough, or from virus-laden hands touching eyes, nose, and mouth. Overall, most cases are mild, but can cause severe illness and death. And I think the latest numbers I was reading is, up to 30% or even higher can have long COVID, which can lead to extended immunocompromised concerns and extended treatments for patients and requirements. So what's interesting was I actually also just recently read a study that patients, even with mild COVID, are 6 times more likely to end up as diabetics post-COVID. So yeah, so there's a lot going on with this too that can also lead to some additional secondary immunocompromising characteristics, even with mild cases of COVID. All right, so moving along, because again, I want to get you guys out of here in a proper amount of time. So let's talk about definitions of when we talk about doing cleaning or disinfecting or sterilizing, okay? These are really kind of different tiers and different levels. So cleaning is really just doing that quick wipe off, right? It's the removal of gross contamination or gross items from contaminated instruments and areas without necessarily killing the germs. This is taking a bleach wipe and doing just a quick wipe off to get all the dirt, grime, materials, crumbs, whatever, off of the table. Disinfecting is a process that involves killing a percentage of the germs. And so I actually grabbed, since I'm in my husband's office, I grabbed some bleach wipes that he had. And it's interesting because they do give instructions. So to clean and remove allergens, you just wipe the surface clean with the product and let it air dry. To disinfect and to deodorize hard, non-porous surfaces, you wipe the surface and use enough wipes for the treated surface to remain visibly wet for 4 minutes. And then you let it surface dry. So you do a quick clean for it to start, and then you go back through and re-wipe it down. And then sterilizing involves killing 100% of the germs, including endospores. Excuse me, I can tell my voice is starting to shift a little bit again. So if it starts to drop off again, let me know. We'll go from there. But there are distinctive differences when we talk about, again, cleaning versus disinfecting. I think a lot of people tend to clean while thinking that they're disinfecting. Sterilizing is a really different process altogether, because usually that involves using a very specific type of sterilant, and we'll talk about that in a second here. So Dr. Van Titus did a study 22 years ago, my goodness, and basically she took a bunch of hearing aids that had come into her clinic, and she wiped them with a Q-tip kind of thing and with a swab, and basically put them on the little trays and to see what popped up as far as different microbes. And this is all the stuff that she found. And this was basically just hearing aids being dropped off by patients. So this is just all the stuff that's in there, right? So stuff that includes like stuff that can cause pneumonia, sepsis, meningitis, external, otitis externa, respiratory disease, folliculitis, pneumonia, osteomyelitis, UTIs that they found like UTI bacteria in them as well. Chronic otitis media, otitis external, otitis externa, and all these different ones that can cause all these different types of diseases. So even if you have that patient, right, that wears the hearing aids and take them off and they drop them off in your hand, this is potentially what you are acquiring in your hand, right? And then you have to touch things. So we'll get into how to hopefully like at least decrease this capability. I always like to tell the story when I was in clinic of a patient who came in because she was very upset that her dogs had chewed the hearing aids, right? So she hands me the hearing aids and I'm trying to figure out if there's any kind of ability to fix this. And then she throws me the lovely little, I had to wait for the dog to pass it first. And I was like, oh, yeah, these are now in the trash. Yeah. So, so those are always the fun little stories that we like to remember from however long ago, right? All kinds of fun stuff. Regulatory agencies. So we're going to jump into this really quick. So OSHA, so Occupational Safety and Health Administration, governed by the Department of Labor, works with the state affiliates, and it regulates the workplace to ensure that we have safe and healthful work conditions. And they are the ones that issue the fines for noncompliance. This is where we actually get into fines for things like not having an infection control plan. Okay. So it can be anything from basically, other than serious violation, that can be up to a $7,000 penalty, up to like a $70,000 penalty if it's a repeat violation, and if it continues to happen. And so we know, like, again, all the stuff kind of moves up from just, oh, I wasn't aware, to I was aware, I know about this because I've had to take these classes, and we're still continuing to not engage in this. This just lets you know potentially what problems you may run into. The EPA is our environmental protection agency. They're there to protect human health and to safeguard the natural environment. They oversee the Federal Insecticide, Fungicide, and Rodenticide Act. And basically, all sterilants and chemical disinfectants are registered with the EPA. They also reveal the hazard data for the chemicals. So all the qualified disinfectants that we talk about that are qualified to work in the hearing aid clinic, whether they have alcohol as part of them or not, because we kind of tend to lean towards, and we'll get into this, about not having alcohol in your disinfectants if you're dealing with those with hearing devices, because we don't want to degrade the actual parts and pieces of the devices. But you can use ones that have alcohol that are highly effective if you're using splash surfaces or touch surfaces, countertops, that kind of thing. But the EPA is the one that's in charge of all those things. That has kind of an ongoing registered list of products that are available. The Food and Drug Administration, right, governed by the Department of Health and Human Services, they ensure the safety of medical devices. So all of us that work for a manufacturer have to, all of our products are FDA compliant, and we have to, everything that we talk about, everything that we say out loud has to be approved. Has to be language that's approved by the FDA. They also operate the National Center for Toxicological Research, and that basically looks at the biological effects of chemicals, including all those sterilants and disinfectants. Sometimes they do that in conjunction with the EPA. The CDC monitors disease emergence and presence both globally and domestically, and they provide the guidance for laws and regulations in conjunction with other government agencies, as we have seen with the CDC involvement with COVID when COVID came out. So, universal precautions. So, we're going to do a quick background on this here. So, in 1987, the CDC developed a set of guidelines for healthcare workers to prevent cross-infection of bloodborne pathogens. And this was done because of the AIDS epidemic. Formerly, it used to be known as the Universal Blood and Bloodborne Pathogen Precautions. And it's just now commonly known as universal precautions. This has been expanded to include all potentially infectious substances, including cerumen. So this is where bloodborne pathogens comes into the hearing aid clinic and where it comes into our background. Okay. and why it all ties together. So we talk about universal precautions. So guideline 1 is that appropriate personal barriers, gloves, masks, eye protection, gown, etc., must be worn when performing procedures that may expose personnel to infectious agents. So what this means is gloves should be worn anytime the hearing healthcare practitioner can come into contact with cerumen or bodily fluids. They should be disposed of after use with each patient. And safety goggles and masks should be worn in the possibility of airborne contamination. So this is going to be, when we talk about airborne contamination and safety goggles, we're looking at not only droplet transmission, but also if you are doing any kind of modifications, right? If you're using a Dremel or any kind of modifications where you're putting things into the air that potentially could be contaminated. So you have those patients with those custom devices that have earwax or earwax particles on them or cerumen particles on them, and you're using a grinder on them, and that's sending all the stuff into the air in extremely small particles. Guideline 2, hands must be washed before and after every patient contact and after glove removal. So the CDC has acknowledged that hand hygiene is the single most important factor in the control of infection. Good hand hygiene practice can contribute to the reduction of healthcare-associated infections by 15 to 30%. Hand care is also important as well, although through thorough washing and drying, you want to apply hand cream or moisturizer regularly to avoid cracked skin. Do not, and anybody who's been through this will know, this is a hard rule, do not hand wash and apply hand sanitizer immediately afterwards. It will not feel good, it will hurt, and it will not help you. So what this means, 80% of microorganisms reside within the first 5 layers of the skin, and approximately 10 million aerobic bacteria reside on 1 single square centimeter. Resident skin flora is deep-seated in sweat glands within skin crevices and hair follicles and under fingernails. They're more resistant to mechanical removal with soap and water than transient flora. It's a lower pathogenicity, and it can protect the skin. But like we talked about with that transmission, it can be pathogenic if it's transferred to other susceptible sites. We talked about transient skin flora. They don't reside on the skin, but they colonize it and are easily acquired through touch. They typically don't reside on the skin for more than a few hours due to your skin's inherent antibacterial properties. Okay. So again, we want to make sure the hospital grade soap is used. And then if you don't have particles, you can use like a no rinse degermer or a hand sanitizer. But just be aware that oil-based lotions can break down latex gloves and should not be used. Advantage of hand washing is, advantages is cheap and readily available. It effectively removes all those transient microorganisms, but it does require facilities for washing and drying, requires space and plumbing, requires time, and can damage the skin. So the mechanical action of hand washing will remove transient microorganisms from the skin along with dead epithelial cells. However, while washing hands with liquid soap and water suspends organisms in solution, which enables them to be washed off, ordinary soap has no antimicrobial activity and doesn't reduce the microbial load off of the skin. We talk about hand gels. It doesn't require additional facilities. They may be useful for community-based healthcare workers where access to facilities may be lacking, right? This is one of those situations where we really want to make sure that perfection does not get in the way of progress, right? If you can't be perfect with hand washing, gels are something that's there and it's there to help you, right? The CDC released guidelines for this for hand hygiene in healthcare situations that supported the use of alcohol-based sanitizers, and this is now considered the gold standard for routine hand decontamination, right? So people talk about gel in, gel out. They are effective immediately against a wide range of organisms and are approximately 100 times more effective against viruses than any other form of hand washing product. So the only downside to this, when we talk about this from a disadvantage perspective, is that it isn't a cleansing agent, right? So if there is a presence of dirt or blood or bodily fluids or cerumen kind of a thing, this isn't there to clean it. It's not going to be effective that way. It's ineffective against bacterial spores. It is an astringent, so it can make your skin stain if it comes in contact with any breaks or any tears. can be harmful if it's accidentally ingested. So if you've used hand sanitizer and then you go and grab lunch and you haven't washed your hands, potentially could have it. And then there are restrictions on it because it is highly flammable as well. You do potentially also risk the issue of clearing out the good bacteria that's on your hand and the resident bacteria that is appropriate, while also taking out the bad bacteria. Splash and touch surfaces must be pre-cleaned and disinfected. So that's universal caution number 3. So what this means, so a touch surface is something that can potentially come into direct or indirect contact with hands. This can include service areas, countertops, armrests, right? End tables, if you have them. Splash surfaces can be hit with bodily fluids, and this can include an area that a patient can sneeze on or that possibly contaminated instruments like hearing devices can touch. Universal precaution number 4. So all critical instruments must be sterilized. What this means is that items that come into contact with cerumen are considered critical. This includes cerumen removal tools and reusable specula, and these should be sterilized using cold sterilization techniques. Guideline 5 is that infectious waste must be disposed of properly. And what this means is items that come into contact with cerumen are considered critical. This includes cerumen removal. Oops, did I go backwards? I did. Most waste generated in the clinic is not considered infectious, but waste containing excessive amounts of cerumen or blood is. So infectious waste is to be placed in an impermeable bag and disposed of with other waste. This just prevents unintended casual contact from others. Practical applications. Guys, I promise we are almost finished. So I know we just have a little bit more time left to go here, and we're going to try not to go too far over. So for hand hygiene, remove all jewelry, start water and place soap in the palm of the hand, scrub it for 10 seconds, rinse and access paper towel, dry hands, then turn off the water. For gloves, bandage any wounds before putting them on and use tightly fitting gloves. To remove, using your gloved hand, pinch material of the other glove and peel the glove off. Keep the first glove inside the second, insert your index finger into the other glove and peel it off the opposite hand, and then dispose of both gloves into the garbage. For surface disinfection, so after you remove objects such as hearing devices, spray or disinfectant on the surface, wipe it off with the paper towel to clean it, because remember we're talking about cleaning versus disinfection. Spray the disinfectant again and leave on the surface for the designated amount of time. So this is referred to as basically kind of what they call the dwell time or the kill time, and that's how much time is needed to kill the microbes that are in there, or to disinfect from the microbes. And anything that offers a disinfectant will give you the amount of time that's needed. After you go through the time, dry the paper towel. For sterilization, bring the containers with contaminated materials into the sterilization area. Wipe down the instruments with a towelette or a paper towel. So this is about the cleaning part of it, right? To get rid of any materials or any excess things that are on there. Using gloves, submerge the instruments into cold sterilant solution, usually overnight. So to sterilize, we'll get into this too here in just a second about the materials that are available. Ideally, overnight gives you the best amount of time to do it. Remove the gloves and wash your hands. After sterilization, put on new ones and place sterilized instruments into a rinsing tray. Rinse them in the sink, allow them to air dry, and then return them to appropriate location. So if this is not telling you that you should be buying, stock in glove manufacturers, I don't think anything else does, right? Otoscopic examination. Put on the gloves, perform the otoscopic examination of the first ear. If there's drainage or infection, change the specula before looking in the second. Holding the base of the otoscope, remove it with the other hand using tissue or gauze, and dispose appropriately. So using this will allow the clinician to continue with the insert earphone insertion with the same gloves, and return otoscope to the original place. For insert earphones, using gloves, attach the tip, insert into the ear canal, remove the gloves, perform your testing, put on a new pair of gloves, remove the insert earphones and dispose of tips, and remove gloves and wash hands. The reason that we take them on and off and put on new gloves is that we're not contaminating your audiometer with, when you're pushing the buttons and touching the buttons, because you've contaminated the patient's ears, or because you've contaminated your hands from the patient's ears. So prior to testing for standard earphones, make sure they're positioned in the appropriate manner. After you're done testing, remove the earphones, clean them with disinfectant, and using a new disinfectant towel, disinfect the earphones. Return them to a useful place. If infection is present, please use gloves. With that. And then with covers, place a new earphone cover over each earphone. Place the earphones on the patient in the manner. After removing the earphones, remove the covers and dispose of immediately. And of course, use gloves if infection is fully present. For tympanometry, insert the previously disinfected probe tip into the ear canal. Post-testing, remove the probe tip by the stem, dispose of it appropriately, either in the waste bin or in a separate covered container. Gloves are good, but they're not necessarily required. For impressions, wash the hands, insert the auto block, prepare and inject the impression material, complete the paperwork, and prepare the impression box while the material sets. Put on gloves, remove the ear mold impressions and place immediately into the box because, again, you're potentially putting your hand in contact with something that has cerumen in it. Remove the gloves, wash your hands, close the impression box, place in the overnight bag, and disinfect the surrounding surfaces. I know we're kind of rushing through this. Are we doing okay so far with everybody? Make sure we're good.
You're doing all right. We're getting close to 3. You're doing just fine.
Yep. All right. We're almost done. I promise, guys. So this is actually one of the big key ones here, I think, is receiving a hearing aid. So this is something that we tend to get from a lot of patients. Go ahead, wear gloves, have the patient place the hearing aid either on a towelette or a paper towel, or use a container, right? When cleaning hearing aids with a pick, use eye protection so it doesn't fling up somewhere. Clean and disinfect the hearing aid, clean and disinfect the instruments. Sterilization may be needed if you're dealing with any ones that are coming in contact with cerumen or blood. Remove gloves and disinfect the surrounding areas. We'll jump into electroacoustic analysis later from this, and then for modification procedures, again, clean and disinfect the surface. Before grinding, make sure you have appropriate protection. Stand behind the barrier if possible. Disinfect all this before putting it in the patient's ear, and then disinfect all surfaces. And then remove your eye protection and discard your mask. Hearing aid drop off. Front office person should receive these in an envelope or a box. Patient place the hearing aid into the container. They will then be sealed while the patient fills out the information form. Once they're done, it's attached to the box. And then after that, the front office person should clean and disinfect those areas as necessary and wash their hands. Products. So heat sterilization is typically done with an autoclave, not recommended, and it's not financially feasible, so we're going to skip right over it. Cold sterilization. This is actually important. It's done with liquid chemicals. So EPA has approved liquids that are containing either 2% or more of glutaraldehyde, like Wavicide. 10 hours of soaking is recommended, or 7.5% concentration of hydrogen peroxide, like Sporox. 6 hours of soaking is recommended. Soaking for less than recommended time will yield a high level of disinfection, but will not actually achieve sterilization. For hand hygiene, use of hospital grade antimicrobial soap is recommended. And then additional items include safety goggles, a lidded container for contaminated materials, latex gloves, ultrasonic cleaner, lab coat clothing protection, and air purifier. There are a whole list of things that are qualified disinfectants that actually are appropriate for even COVID, that talk about like Clorox hydrogen peroxide wipes, Cavicide, Sanicloth, Stanozide. All of these things are things that are appropriate. Most of them are alcohol free and are part of list N, which is the list that is things that are considered to be either effective because they've been tested and proven for COVID, or they've been tested on an even harder to kill virus or another similar human coronavirus. So jumping into an exposure control plan with 1 minute left. So basically just wanted to establish the layout for this. For exposure termination, it just depends. For Washington, you have to include contact related information, but you do have to provide job classifications in which some or all employees have potential occupational exposure to bloodborne pathogens. Okay. You have to show what infection control system you're using, have safer medical devices and equipment used to minimize occupational exposure. You have to list what you have for personal protective equipment and the work practices for housekeeping and laundry labels. Have a record of patients have a Hep B vaccination as well. You have to provide information on the training class that you provided, the contents of the employee training, like one of these, location of training materials, and the location of training records for employees in case anybody should ask you for OSHA. Also have an established procedure after the initial first aid is given if somebody is exposed to a bloodborne pathogen, administration of that evaluation and follow-up, and then review the circumstances of an exposure incident. We do recommend that you have medical records, technically a sharps injury log, which we're not really going to have to deal with here in the hearing aid clinic as much, and sources and resources. So a lot of stuff is either from basic infection control or from Dr. Benkitis herself. If you're looking for the plans for the exposure, for your exposure control plan, we have it for lni.wa.gov or osha.oregon.gov. And we are at 3:01. How's that?
Fantastic, Tammy. Fantastic. Did you take a breath or have a drink of water at all?
Yeah, barely. I know I ran through that. There's a
I've
lot
seen you do it before.
an hour with you. Does anybody have, I actually checked the chat here. Does anybody have any questions about it?
There's not been chats. We've just been sitting, listening,
Okay.
absorbing.
Yeah.
Does anyone have any questions? Go ahead and unmute yourself.
I have 2 comments. I believe Oregon requires you to wash your hands for 20 seconds.
Mhm.
And also for sterilizing your equipment, or in my case, I do loaner aids and demo aids. When they come back, I wipe them down with the alcohol, but then I have in ultraviolet light. I can put them in there for 10 minutes and that sterilizes and kills all of the germs on them. So if they've got an ultraviolet light, they can, after they clean them down, wipe them down, and sterilize them that way.
I don't have any information on ultraviolet light as a sterilizer. That's again just part of what potentially could have been missed for research. So I wouldn't. I'm not saying anything. I'd say being totally neutral about the UV stuff because I just don't have that information. So it's actually something good to kind of look at more too, as far as what's truly in there. It is not recommended. It isn't recommended to do to use alcohol wipes. I know we do them all the time, and it's just easy to have in there. I know that. But that can degrade the material as well and even make it more susceptible to having infectious control or having bloodborne pathogens, that kind of stuff. Get into kind of those more like micro nooks and crannies, right? So
I said alcohol wipe, but yeah, what I have is not really the alcohol wipe.
Oh.
I'm just using that as a generic term.
Sure. I just want to make sure, like, just from a clarity perspective, that yeah, it's not technically recommended. I know there's like a lot of different sites that have things that have non-alcohol or alcohol too, right? So we do recommend if you have something that's alcohol based, that's a disinfectant, you can use those on tables and splash surfaces and touch surfaces. And then ideally use the non-alcohol versions on hearing devices or those kind of things that are potentially going to be affected or in touch with hearing devices or have those rubber gaskets and that kind of stuff. But no, that's a good thing, a good point to look out for UV stuff. I just hadn't looked at it yet. So
UVC is what you want to look for. UVA, UVB does not. But UVC is used in hospital settings now to actually sterilize rooms.
Oh, perfect.
A 9-watt UVC bulb will fry just about anything organic within a few minutes. Very effective.
We'll keep our distance then, right?
Absolutely, and don't look at it; it'll burn your eyes.
Yeah. All right. Cool. Very good. I will have to add that to the next version of the talk then to make sure that that's in there too. Any other questions about anything? Again, I know we dove right into it and jumped right through it. I want to make sure you guys if you have any questions, I'm happy to answer them as best I can. For 3 o'clock on a Friday.
I'm sufficiently creeped out.
Good. I have done my job. That's always my goal. So everyone should feel to bathe in hand sanitizer and at least just wash your hands a few more times a day for at least a week, okay?
Got to stay on it. All of us do. Okay. Anyone else? All right, Tammy. Well, thank you very, very much for being here and last night as well. So I'll go ahead and